Welcome back to Module 2, talking about pain in palliative hospice and end-of-life care. So in this video, on Section 2, we're talking about pain assessment. So pain assessment is, like I harped on in the last video, very, very important. As you're assessing the pain, it's important to take a pain history. What has been this patient's experience with pain, and are they experiencing acute pain or chronic pain? Within your physical examination, you are also going to be doing that interview, asking the patient lots of questions, and you will be reviewing laboratory and diagnostic findings. So it's important to think about the whole aspect of pain, the psychological, emotional, social, spiritual. Is there any existential suffering? Is this pain being undertreated? What is the tolerance to pain of the patient? Is there some sort of risk of substance use? Remember, it's something we keep in the back of our head. If there is a history, then the patient may or the family may be underreporting, or the family may be resistant to having pharmaceutical intervention, especially with opioids for pain management. What is the support system that the patient has? And then, of course, you're thoroughly documenting all of your assessment. The goals really are to determine what's going on with pain. So within your pain assessment, you're thinking, what is the etiology of pain? Because understanding where it comes from is going to help you to treat it. Is it nociceptive or neuropathic pain? You're going to treat those differently. With neuropathic pain, opioids are not going to touch it. You need to use something that works on the nerves, not the opioid receptors. Is it acute pain, chronic pain, or acute on chronic pain? And what is the response to the pain interventions? Because how the patient responds to what you're doing determines how you continue moving forward with pain management. Is it working? Great, keep doing that. Is it not working? It's time to revise the plan. That's why that continued assessment and reassessment is very, very important. The pain experience is going to be unique to each individual. So patients are going to describe the pain differently. We talked about the different language that can be used. Within the experience, it's important, and the assessment, it's important to look at the location, intensity, quality, timing, aggravating or relieving factors, what works for the patient and what doesn't work. So palliative patients have, on average, at least 4 sites of pain within their pain experience. So that's why locations are very important. Remember our last guy, he had the neuropathic pain, he had the incisional pain, he had the phantom pain. So there's a lot of different types and locations of pain. And within that assessment, it needs to be more than, what is your pain on a scale of 1 to 10? If they say an 8 and it says, oh, give 2 Norco for pain 7 to 10, and you call it good, what if it is phantom pain? What if it is neuropathy? You're not going to manage that pain by giving the patient 2 Norco. Also assess the meaning of pain. Remember, pain can be emotional as well. It could be existential. Does it mean that the patient is being punished? Does the patient think that the pain means that the chemotherapy isn't working? What is the meaning of the pain to the patient, and how do we address that psychological aspect of the pain? And then think about, how is pain impacting the quality of life? Cultural considerations we've talked about. Pain means different things in different cultures, and different people respond differently to pain. So as you're doing that assessment, think, do I need to ask different questions based on this person's background? What are the medications that have helped in the past? When I'm asking a patient about their pain, in addition to saying, okay, where is the pain? How bad is this pain here? Trying to determine the type of pain and location of pain, I ask, what's helped in the past? If they say, well, actually, this is an example of nausea, but I had a patient with hyperemesis who we were giving her Zofran, and it wasn't doing anything. And she says, I always take Benadryl for nausea. And I mean, Benadryl, it kind of sort of is an off-label use that can work for nausea, but it's not commonly used. So in asking her what's helped you in the past, give her that Benadryl, and oh my goodness, she finally has some relief from that hyperemesis. So what's working now, what's not working now, what's worked in the past. Also consider non-pharmacologic interventions. Often having pharm and non-pharm working together works much better than having just pharmacological interventions. So questions regarding physical, psychological, integrative, other non-drug therapies, what's been tried before, and what can we try again? Goals of care for the patient are important to remember. So the patient goals are going to impact the plan for the patient. They're going to impact diagnostic testing. They're going to impact the selection of pain management therapies. So when I say impact diagnostic testing, when you have a patient, whether they're palliative, hospice, or end-of-life care, think about what you're doing. And is it necessary? So if this patient is having serial lab draws to look at their H&H, is that necessary? It's giving us information, yes. We are responding with this information, yes. Is this improving their quality of life? Is this promoting suffering? If a patient needs to go for an MRI to see how extensively the cancer has spread, but it's incredibly painful for them to lay still for more than 2 minutes at a time, is it worth getting that MRI if it's already known that it's a terminal diagnosis? Like, what does it matter how far it's spread? Is it worth putting the patient through the pain of that diagnostic procedure? What will we gain? And will what we gain benefit the patient? Within the physical examination of your pain assessment, you are going to observe for verbal and nonverbal cues that might suggest pain. So things like being withdrawn, fatigue, grimacing, moans, irritability, particularly if the patient is unable to report their pain. Those are all things that you can look for and observe to determine whether pain may be present. So examine different sites for pain from trauma, skin breakdown, bony prominences, different things like that, palpating areas for tenderness, auscultating for abnormal breath sounds or bowel sounds. You could be hearing signs of pneumonia, so things like rales, crackles, bronchi, or maybe you're not hearing bowel tones. The patient's abdomen is distended. It could be an obstruction or a paralytic ileus. So that's also important. And then percuss areas for fluid accumulation or gas, especially for abdominal pain, to rule out obstruction, ascites, different things like that. In class, we're going to talk about the dermatome chart. I don't know if you're familiar with that, but essentially it is a chart that maps out which nerves carry pain through what different areas of the body. So that helps understanding the location of the pain as far as maybe the etiology of the pain. Functional assessments are also very important. Is the patient able to carry out activities of daily life? Are they not? What is their muscle tone, their coordination, their reflexes? Are they able to walk without falling down? Are there steps that they have to go up and down? Are they the ones cooking for themselves or their family? And then remember, it's always important to treat the cause of pain consistent with the goals of care. So what are the patient's goals? Maybe the patient's goal is to get up to the bathroom by themselves. Maybe it's to cook dinner twice a week. Maybe it's to walk to the mailbox. But just know, what are the goals and how can we address those goals? And like I was saying here, laboratory and diagnostic evaluation, those can be really helpful in identifying the etiology of pain. Perhaps abdominal pain is caused by appendicitis or a bowel obstruction. Perhaps this pleuritic chest pain is caused by pneumonia and antibiotics are necessary. But it's always important to have that benefit burden ratio in mind. Are these additional tests going to be providing information that helps us achieve the goals of care that the patient has in mind? Reassess. Always, always, always reassess. Remember, pain is not static. Pain is not something that a patient experiences, you give them a pill, and it's all better. It's not like that, and so that continued reassessment is necessary. And if it's going to be oral pharmaceuticals that you are administering to manage the pain, it's important to before that 45 minutes to an hour goes by where it's time to reassess, check on that patient again. Maybe they are in so much pain they can't wait for an hour, or maybe an ice pack or a heat pack, or maybe some calming music or something else needs to be added into the mix. So always reassess that pain and look for how the pain changes and responds. And then, of course, communicate your findings to the team. So if pain is one of those issues that's not being well controlled, it's critical to bring that up to the care team. The nurse, are right there with the patient. You know the patient better than anyone else on the team, and so you are their voice. If pain is not adequately managed, communicate that to the team. Also, document your assessment findings. It's really, really important to document. Nurses, on average, I believe it's only 80% of pain assessments are documented. And remember, if it's not documented, it's not done. So remember to document everything that you're doing. Describe what you're finding as best you can. Location, intensity, limitations, functionality, what medications are being used, how well are they working, and be objective. It's important to just look at what is happening and provide recommendations and bring up that conversation of pain management with the patient, with the family, with the team.